And then we'll highlight some of the common examples. And I'll describe them in the way in which I think about these diseases. And we'll finish talking a little bit about gamma delta, as we heard earlier from our young colleague in the front row here. And then I'll just have one summary slide towards the end. So what are some of the problems we're facing in the classification of these diseases? Well, they're listed here. Unfortunately, in Vancouver, as is true in almost everywhere in the world, our clinical colleagues are having a hard time getting patients taken to the operating room. And so what they're looking to do is to do needle core biopsies, or even smaller. And the problem is these are very difficult diagnoses with a full section. When you then go to needle core biopsies, it gets even more difficult. And it becomes very difficult to distinguish whether something is benign or malignant. Oftentimes, you don't have enough material to do an extensive battery of immunohistochemistry. You often don't have material to do molecular genetics. So this is a real problem that's occurring, and it's occurring all over the world. I listed here angioimmunoblastic type. It can be very hard to distinguish when it's very early in its evolution. It can be very hard to distinguish from reactive processes or other peripheral T-cell lymphomas. You see here the diagnosis of anaplastic large cell lymphoma, ALK negative. That can be very hard to distinguish from other lymphomas, but we'll say a few words about it. Now, interestingly, our case today was a very nice example of ATLL. The problem we have with ATLL is that we see this very rarely in British Columbia. And what happens, it often gets underdiagnosed in areas where the virus is not endemic. Now, you did see the data that came from the international study, and I'll tell you that I was one of the people who went to Japan in 2005 and looked at all those cases. The other thing I would tell you is that most of the North American cases that were part of the international study came from Vancouver. We had by far the majority, about 70% of them. I don't know why, but I think we just worked harder to get the cases organized. But they mostly came from Vancouver. When I went to Japan, to Nagoya in 2005, I've never seen so much ATLL in my whole life. So I must have saw 50, 60 cases while I was there in a period of 5 days. And as mentioned by a couple of the colleagues sitting in the front, it can look like a lot of different things. So you need to think about it to make the diagnosis. We won't talk about this at all, but suffice it to say it's very important to get clinical information, particularly when you're dealing with a lymphoma that has its origin in the skin. It becomes very important. And then we'll say a few words at the end about gamma delta. All right, so I think we saw this slide. If not, just to remind you again, this is from the international study, collected about 1,200 cases from around the world. And by far the most common diagnosis is this category here, the default diagnosis of what we call, what is referred to as peripheral T-cell lymphoma, NOS. What I will show you in a couple of slides is that's a default category. You have to rule everything out before you make that diagnosis, and that's important. We see this disease, which is angioimmunoblastic, fairly commonly in Vancouver. My understanding is it's less common here, and interestingly, what you see a fair bit is nasal TNK, which I'm looking for. Oh, here we go. Here, and you see this fairly frequently, is my understanding, in Mexico. We also see it in Vancouver, as we have a very large Asian population. But the other subtypes becoming extremely small, as you can see, in terms of their frequency. And they're very uncommon, and we won't dwell on them. Just a few more words again about the international study. I think of these in terms of trying to organize them in my head as the common ones listed up here. You can see the survivals are pretty dismal, the uncommon, and then the NK, which are very common. And the only, or uncommon, pardon me. And the main theme here is that in contrast to large B-cell lymphoma, which represents the bulk of what we see and is very treatable and a very curable disease, we have a long way to go with these diseases. We're not doing a good job. And throwing CHOP at them or the different variations we heard, in most cases is not successful. And I won't talk about in this talk, unfortunately, but the only way to success is going to come from sequencing these tumors. We will then understand the fundamental biology of these tumors, and we will recognize novel targets that we never appreciated. We will find all kinds of recurrent mutations in these tumors, I can guarantee it. We're doing it right now in collaboration with Philippe Goulard and Laurence de Laval, who will be here in a couple of weeks. We're doing a collaboration with them in Vancouver, where we're sequencing a large number of T-cell lymphomas. But I also believe we will find fusions, novel fusions that have never been described. And they will give us insight into diagnostics, but they will also lend themselves potentially to therapies in the hopefully not too distant future. I remind you that the IPI works in these diseases. As you can see, there's a p-value. It's hard to read, but it does work. But the bottom line is, look at these curves. They're dismal. And in terms of therapy, again, this is with and without an anthracycline for 2 of the more common diseases, as you can see here, and the outcomes are terrible. We are not doing a good job with these patients. That's obvious. Now, nobody, even me, will be able to read this, but I just remind you that in terms of the classification of lymphoid neoplasms, these are very complicated diseases. And that's why we have some of the experts we heard tonight that live here in Mexico City who do lymphoma, because it is a highly specialized area. Now, I've told Carlos and others that I'm very fortunate that I've been able to spend the last 23 years doing nothing but lymphoma. I don't look at anything else, just lymphoid cancers. And I don't even look at myelodysplasia, I don't look at ALL, anything like that, just Hodgkin and non-Hodgkin lymphoma. So as Gabby, I think, said all kinds of nice things about me, it does become a little easier if that's all you have to do. So that's a 1+. Now, there are several ways to think about T-cell lymphomas, and this is one way. So in terms of fundamental understanding of the types and how to classify them, this is a reasonable framework that's built on biology. So you can think of the innate immune system that is populated by gamma delta cells, these NK-like cells, and then also true NK cells. They function quite differently, and the most important thing is they're not restricted by MHC. They're predominantly the initial barrier, particularly at epithelial sites, and they're very important cells. On the other side of the ledger over here are the B and T cells. These are the specific immune responses that we all know, where antigen is presented to these cells in the context of MHC. And if we forget about B cells for now and focus on T cells, we're talking about alpha beta type T cells, where antigen is presented to them, and they're very important, particularly for the defense against viral infections, but also in terms of tumors. The topic we're discussing tonight is that malignancies can develop in these cells, but this is a reasonable framework on which to think of them. There's another way to do it, which I think is easier, and that's what I do as a hematopathologist, is I think of them based on their primary site of presentation. So I group them this way into nodal and extranodal, which are the most common, and you can see them all listed here, and we did hear about them already. Some of these we will not talk about. And then those that are primary cutaneous, the most common ones are listed up here, but there's also a growing list, as you can see down here, including entities we don't see in Vancouver, but you see here on occasion, although probably pretty rare. And then the disorders that are more systemic or leukemic at presentation, including the one that we heard about tonight. I'm not seeing it. I think it was listed on a previous slide. It should have been here, but it isn't, and that's ATLL, which is frequently systemic. Now, in terms of peripheral T-cell lymphoma unspecified, remember, this is a diagnosis of exclusion, as I mentioned. So you need to exclude the other subtypes of T-cell lymphoma before you put a disease into this category. Remember that there are these very rare variants as shown here, but we won't talk about them, including even a very rare T-cell lymphoma that actually populates follicles and is a malignancy of T helper cells. They're CD4 positive. And so really, peripheral T-cell lymphoma NOS, or unspecified, is really the diffuse large B-cell lymphoma of PTCLs. It is a default diagnosis if you can't rule out any other possibility. It's predominantly nodal presentations. It's generally very aggressive, as we've shown, and bone marrow involvement is quite frequent. So here you see it represents about 8 to 9% of all large cell lymphomas. We've talked about this. We've talked about bone marrow involvement. We'll show you some pictures, but remember, small vessel proliferation, very frequent plasma cells, and eosinophils are very common. It has a mature T cell phenotype that can be seen here, and we see EBV in about 1/3 of cases, but we'll talk about that in a minute too. And it can be cytotoxic or non-cytotoxic. It is clonal and has characteristic cytogenetic abnormalities, although most cases do not. Most cases just have trisomies, but there is this rare follicular T-cell lymphoma variant that is a lymphoma of follicular helper cells that is characterized by this translocation. So here are some pictures. This is a typical morphology with these large neoplastic cells, often with clear cytoplasm. Sometimes they can be very pleomorphic. Very common involvement of the bone marrow. And it can be hard to diagnose in the bone marrow, actually. And then here, expressing CD3, as you can see. Some cases are cytotoxic. So here's one, again, highlighting this issue about the bone marrow, was heavily infiltrated in this case, and all 3 of the commonly used cytotoxic molecules are expressed by this tumor. So some peripheral T-cell lymphoma NOSs, or unspecified, are cytotoxic. Some express CD30, but the pattern of CD30 is never like the kind of disease we call ALK